Good morning, good afternoon, and good evening, everyone, depending on where you are joining us from. And welcome to today's AMR Community of Practice webinar. My name is Sylvester Moyo, and I will be your moderator for this session. Today's webinar is titled AMR Surveillance and Data Utilization for Healthcare and Public Health Decisions. Today, we will be exploring how AMR surveillance data, when collected, analyzed, and applied effectively, can help guide decision-making at clinical, public health, and policy levels. Before we start, just a few reminders. Please note that there is simultaneous language interpretation from English to French and Portuguese. Please select your preferred language using the interpretation icon. Please also use the question and answer section for your questions, and use the chats for comments, links, or resources that you'd like to share with us. We really appreciate that. Please also note that this session is being recorded and will be made available via the ASLM Academy portal. It is my pleasure to introduce our speaker for today, Dr. Lillian Musila. Dr. Musila is a biomedical research scientist with decades of international experience in microbiology, parasitology, human genetics, virology, and molecular biology. She holds a PhD in molecular parasitology from the University of Pennsylvania and has completed postdoctoral fellowships at the National Health Laboratory Services in South Africa, as well as Emory University in the United States of America. For the past 17 years, Dr. Musila has been based at the Walter Reed Project in Kenya, where she serves as director of the Microbiology Hub in Kericho and as the research director for Western Kenya. Her work focuses on One Health, multi-pathogen AMR surveillance, and exploring bacteriophages as alternative or adjunct therapies for multi-drug resistant infections. Notably, she has chaired the technical working group that developed Kenya's first national AMR surveillance strategy. We are really delighted to have her today to share some insights on the practical application of AMR surveillance data and some of the work that she and colleagues and other collaborators have been doing in Kenya. Without further ado, I would like to hand over to Dr. Musila. Dr. Lillian, over to you.
Sylvester, thank you so much for that introduction, and it's indeed a privilege for me to be here today and to share a couple of thoughts about AMR and its applications. As Sylvester has introduced, today we'll talk about AMR surveillance and how we can use that data for healthcare and public health decisions. And by way of introduction, I just want to say that the problem of antimicrobial resistance is a One Health problem, and that's because antibiotics are used in not only the human sector, which we're mostly familiar with, but 3/4 of antibiotics are used within the animal sector. And as a consequence of this, then a lot of antibiotics are found within hospitals, within animals, but also within our environments, and eventually they make their way into the waterways. And so this is why this problem is being tackled by these 4 major organizations that focus on food and agriculture, environment, health, human health, and animal health. And the goal of studying antimicrobial resistance is to preserve antimicrobial efficacy and ensure that there's sustainable and equitable access to antimicrobials for prudent use in human, animal, and plant health. And so the complexity of this problem means that we need to wrap our minds around it. And a lot of work has been done in the human health sector, leading the World Health Organization to declare antimicrobial resistance one of the biggest threats to global health, food security, and development today. I want to show you some statistics which many of us, I'm sure, are very familiar with. And one of the classic papers is by Murray et al. In 2022. That said that 1.27 million deaths were directly related to AMR and 5 million were associated with AMR. And the projections, as you can see on that table below shows that there's projected to be 10 million deaths in AMR. And if you compare this with the deaths of COVID in 2020, there were 3 million. You can see what a disaster that will be. On the right, it tells us that 6 organisms are responsible for 80% of those deaths, but the highest deaths are in sub-Saharan Africa. And in sub-Saharan Africa, strep pneumo, which is a vaccine-preventable disease, is the leading cause of death. And so we look at these projections, but we hardly consider what data lies behind getting these types of numbers. And when I looked at the data sets for Lancet, this Lancet paper, they studied 23 pathogens and 88 pathogen and drug interactions. And they collected data from 204 countries. Some of the data sources were literature reviews, but hospital systems, surveillance systems, and other sources. And all of these data allowed them to predict some of these models and to give us that data. I think the sad thing is that they had the least data from sub-Saharan Africa, and this just reveals what a gap there is in accurately understanding what this problem of AMR is, particularly in low and middle income countries. Peter Drucker, a famous economist, said you can't manage what you don't measure. And so when we don't have data, accurate data, we can't answer questions like these. In the clinical sphere, what bacteria are causing infections and what are their drug-resistant patterns? So do we even have baseline data? Are the current antibiotics we are using effective, and are we using them responsibly? When we have outbreaks in hospitals, can we detect them, and can we measure if our IPC measures are effective? When we look at genetic questions, we ask things like, what are the strains and drug resistance profiles of the bacteria causing infections? Can we identify which strains are emerging and what their resistance patterns are? We get vaccines for our populations, but are these vaccines effective against our endemic strains? And in the One Health sphere, do we understand which of these sectors are the main drivers of human infections? And what role do these sectors play in AMR? And finally, do multi-drug resistant bacterial strains move from animals to humans to the environment? So without adequate data, we cannot answer any of these questions. So the World Health Organization recognized the importance of AMR resistance and surveillance, and they've been pushing for each country to adopt national action plans. Again, what we note even from this figure is that if you look at the blue ones, those that have enrolled in both AMR and AMC, antimicrobial consumption, you can see that many countries in Africa are doing both, but many are still just collecting antimicrobial resistance data. And what this report from 2024 shows is that there's still a limited number of enrollment by low and middle income countries. And part of the problem is limited financial or human resources. And so clearly this surveillance gap limits our ability to understand the degree of the problem. Now, Kenya was one of the early adopters of the National Action Plan, with one instituted in 2017. It was quickly followed by an antimicrobial resistance surveillance plan. And then subsequent to that, every year they publish a report on the surveillance across the country. In the recent update of the National Action Plan that was published in 2023, we were very pleased to have a very strong One Health focus. The initial plan was largely based on human health. And so now we've incorporated this One Health agenda into the National Action Plan. And just last year, we've adopted a genomic surveillance system to understand not just the pathogens, but also the genomics behind AMR. So we've made a lot of important strides. But one of the strengths of the National One Health Surveillance site is that we have 2 strong reference labs in the public health sector and in the veterinary sector. And that if you look on the right map, it shows the overlay of the sites for animal and human health. And as you can see, we've tried to put a human health site close to an animal health site. And what this does is it helps us see mirrored antimicrobial resistance so that we can understand what's happening in both sectors in the same geographical location. And so this is really one of the powers of how the surveillance network has been set up. And so what this allows us to do, as you can see in the antibiogram on the left, is that we can look at drugs that are used in both the human sector, like gentamicin and tetracycline, that are also used in the human sector. And we can see where is resistance growing quicker and what are the resistance telling us about which sector is driving antimicrobial resistance. So that's just a quick overview of how the surveillance system is set down. But really the power of this data is that there's an integrated information management system so that all the data from the human health sector and the animal sector meets inside a central data warehouse. And so this data can be combined to produce human health reports, animal health reports, and those reports can be analyzed together because the data sits in one place. And so this is really the power of a very well-designed national surveillance system. Now, on top of that, in my laboratory and in the microbiology hub in Kericho, we've been doing active AMR surveillance for more than 10 years now. And we have a similar approach, and this is how we set up the national approach, that we have sites that run across the whole country, as you can see on the right. And we analyze mostly human health data using sentinel hospitals. And we focus on escape pathogens, which are some of the main ones that we saw that cause a lot of the morbidity and death, and also enteric pathogens as well. And we use a number of different techniques so that we can understand the phenotype, the molecular and genomic characteristics of the organisms that we study. So we can look at their ID, their AST, the resistance genes, their strain types, and their virulence. And we're very fortunate that all the techniques and technology for looking at all of these characteristics are resident within the lab. So we can do robust identification, particularly leveraging the MALDI-TOF system. We can do genomic characterization from molecular to whole genome sequencing to metagenomics, and we can also do typing, both molecular and serological typing, and looking at virulence factors. And so what I want to do is I want to demonstrate to you a couple of use cases using both our work, but also work from literature that shows how these different surveillance strategies can be used to drive decision making. There are 5 use cases I want to focus on, and the first one is how do we use epidemiology and evolution of bacterial strain types and resistant strains? The second is how do we use the ability to detect resistance genes in inferring their location and spread. The third is outbreak detection and response. The fourth is how do we identify the sources of AMR and transmission cycle. And I'll end by us looking at a case study for the use of artificial intelligence in AMR. And so let's move to our first use case, which is tracking the epidemiology and evolution of bacterial strain types. And I'm starting with E. coli, which is a pathogen we've been tracking for a long time now. And on the left in this graph, I want us to focus on this really dominant ST type for E. coli, ST131. ST131 is the most dominant global strain. It's considered a high-risk strain. And you can see that in the years up to 2019, this indeed was the most dominant strain. In 2018, you can see ST38 also picked up. But right after this COVID period, you can see that this other dominant strain rose, ST1193. And you can see that this is the second dominant global strain, but in Kenya it has become the leading strain. And so why is this important? If you look on the right here, this E. coli strain came with its own very unique characteristics. And one of them was, if you look at the susceptibility profile here, whereas many of the old E. coli strains were largely susceptible to antibiotics, this new strain, you can see with this dramatic dip, is non-susceptible to many antibiotics, and in particular, these last-line antibiotics, tigecycline, meropenem, aztreonam, and our second and third line, fourth line, cephalosporins. So the shift in strain types also represents a shift in resistance patterns, which means that whereas E. coli was an innocuous strain in the past, now it's a strain that brings along with it significant multi-drug resistance. Now, we occasionally get outbreaks of cholera in Kenya, as I'm sure in many other countries in Africa. And as we tracked the cholera strain types, we typically have a dominant strain type, ST69 of cholera in Kenya, and I know within Eastern and parts of Southern Africa. And as we looked at outbreaks in an outbreak in 2019, we suddenly found this very unique cholera strain, ST8. And this ST8 was linked to strains only found in Austria and in Asia, and it suddenly popped up in Kenya. But when we looked at when these strains emerged, it coincided with an international training exercise. So people from different countries had come into Kenya, and then we got this very unique strain of ST8. Now, what was unique to this strain is that it carried carbapenem resistance genes and genes associated with colistin resistance. So again, we're getting new strains that are very different characteristics from the prevailing strains. And so what does this mean? It means that we need to look at triggering events for emergence of new strains. This could be international training exercises, it could be big trade shows, it could be a sporting event that mixes lots of nationalities together and introduces new and highly dangerous strains. I want to talk about a third application of tracking strain types, and this is related to vaccines. And I want to talk about Streptococcus pneumonia, which I mentioned in the introduction is the leading killer of AMR-related deaths in sub-Saharan Africa. And pneumococcal vaccines have been introduced, and what they've seen with the introduction of these Streptococcus pneumonia vaccines is that in the vaccines, they try to incorporate quite a number of the dominant serotypes, but strep pneuma has many, many serotypes. And when they introduce a vaccine, you can see on the graph on the top, they find that those strains that are represented in the vaccines decline significantly in terms of their impact on disease. But what you see is that non-vaccine related strains then suddenly surge. And then when they try to improve those vaccines, so for instance, they went from a 13 type vaccine to now a 23 type vaccine, they find that very quickly you find the same pattern. And so you could find here on the right, for example, that the orange bars represent the types that are in the vaccine, and you find that although they remain dominant, you see that the non-vaccine strains begin to increase over time. And we see that as well for the Pneumovax 23, that non-vaccine strains begin to increase. And what they've found is that these non-vaccine strains tend to be highly invasive in nature and also have very high levels of resistance to antibiotic. And so this reduces the effectiveness of the currently available pneumococcal vaccines. So what are we saying here? That is, if you're not tracking the strains that are in your vaccines, then you might actually be reducing the gains of the vaccine over time, and surveillance is key to keeping on top of this. So we'll move to the next use case, which is identifying resistance gene, where they're located and how they spread. So I'm going to start by looking at methicillin-resistant Staph aureus, which again is an organism we've been tracking. And you can see that as we were doing surveillance in the early years, that the levels of MRSA were very low. We would hover around maybe 7% or less than 7%, as you can see from the early years, 2015 to 2020. But in 2021, we began to see an increase in methicillin-resistant Staph aureus, as you can see. And now we have about 19% of our Staph aureus are methicillin resistant. And this coincided with a shift in the SSC-MEC types, and the SSC-MEC cassette is what carries the MEC-A gene that confers resistance to the MRSA. And you can see that this change coincided with an increase in SSC-MEC types 4 and 5. You can see this in the two graphs in the middle. And you can see that this increase also increased the numbers of antimicrobial resistance genes associated with these MEC types, and also increased the number of virulence that were associated with MRSA types. And so again, you see that the strain type correlates with a significant shift in resistance genes and virulence genes as well. Now, this rise in MRSA was not distributed across the country, and we were able to identify within Kenya hotspots for MRSA. And you can see that in Kenya, we have hotspot in Nairobi, where MRSA levels are 15%, and also in Lamu on the eastern coast of Kenya, where the rates are MRSA. And so you can see that we can now begin to define and refine the risks and see where geographically these risks are located, which means we can then do some targeted questioning and investigation to find out what is driving this high proportion of MRSAs. Now, we've done the same with carbapenem genes, which we're tracking because of the very high resistance to cephalosporin drugs. And we found that the numbers of carbapenem resistance genes are increasing. But when we mapped it, we also found that these genes are increasing not evenly across the country, but there are hotspots. And in this case, we found hotspots in Western Kenya and in Nairobi, the capital city, which is not a surprise because that's where most of our major hospitals are. But again, you can see that these types of risk maps helps you focus your interventions into where it actually matters. So in addition to those particular resistance types, we've also identified novel genotypes of other strain types of other gram-positive bacteria. I've mentioned the novel SEC-MEG types that have been emerging. We've also identified new mutations that confer resistance to last-line drugs like colistin, and also novel MRC genes that again confer resistance to colistin. And so these emerging genes just give us an indication of how likely we are to lose efficacy in our drugs. And it's concerning when they're resistant to last-line drugs like carbapenem and colistin. I want to highlight a recent finding that we have is that because of the increase in carbapenem resistance, there are some global funders who have moved to introduce cefiderosol, which is a fifth-line cephalosporin, into countries around the world, and Kenya being one of them. And we began to notice in some of our organisms that we are already seeing resistance to cefiderosol even before it's introduced. And so this gives us a really nice opportunity to track how quickly after introduction of cefiderosol would we find resistance and how quickly will it emerge. But it also tells us that perhaps we should introduce it only in those regions that I showed you in the previous slide where carbapenem resistance is very high, and not to roll it out across the country. Now, we're seeing an increase in multi-drug resistance. And so the question is, how does resistance spread? And most of these resistance genes, especially the ones that move, are spread on conjugative plasmids that disseminate AMR genes across bacterial pathogens. These plasmids that encode ARG, antimicrobial resistance genes, they tend to be mobile, and they also tend to have a broader host range than the others. So a plasmid can live in Klebsiella and can also propagate in E. coli and maybe other gram-negatives. The example I'm showing you on the right is a Klebsiella pneumonia multi-drug resistance that carries a basket full of resistance genes in its plasmid. And you can see that in one move and one acquisition, a previously susceptible E. coli can, by acquiring a single plasmid, become resistant to all these classes of drugs. And so these mobile plasmids are actually the biggest drivers of resistance. And there's a nice quote I found in AMR that says that the ability of AMR plasmids to transfer independently presents a very serious challenge for epidemiologists who are trying to monitor the prevalence and spread of AMR. And they point out that the pattern of transmission of plasmids and genes might be distinct from those of the host bacteria. So because these plasmids move independently, that perhaps we should be tracking those plasmids and not the bacteria themselves. And this next slide just shows something that we've been trying to do in our lab, where we've identified highly multi-drug resistant isolates and mapped how many plasmids do they have. So it's a type of plasmid surveillance, and we can do this using our long-read sequencing. And you can see all these gram-negative bacteria on the left, but here we've actually counted how many plasmids are they carrying and what types of plasmids are they carrying. And we began to look a lot at these plasmids and how do they move, which ones are broad range and which ones are not. And this will become one of the main focuses of our surveillance because of the risk of plasmids. Now, the biggest example of how quickly resistance can spread through plasmids is colistin. And colistin resistance was first detected in China with a plasmid encoded gene called MCR1. And very quickly it moved, and it was found in isolates from livestock. And it very quickly moved around the world, and now I think we're on MCR 13, maybe, different genes that are carried on plasmids. And just in the last couple of years, we've identified 2 novel colistin resistance genes encoded on plasmids, MCR8 and MCR10. And so we know that these are knocking around in Kenya, and we're losing our very last line drug. Now, the interesting thing is that we found these plasmids in humans, but we know that we don't use colistin a lot for human health. But in animal health, colistin is used a lot. And on the right, I'm showing you the annual report on antimicrobial agents for use in animals. And you can see where colistin sulfate lies, kind of mid-level here. And it's used a lot in the poultry industry, and it's not very strictly regulated. But it's been flagged as one of the drugs that are medically important that should be high priority for phasing out in animal health for use as growth promoters. And so you can see again what the importance of this One Health. But because we want to track why we're getting these plasmids popping up in our human surveillance, we've designed a study where we're partnering with our partners in East Africa, the Vet College, the Livestock, ILRI, the International Livestock Research Institute, and also our partners in Rare Africa, to look at gram-negative pathogens and from the environment, from human and animal, and look at which genes are in these organisms and which ones are the drivers of resistance. And we're going to screen all these isolates for colistin resistance. And since this is not a typical assay, we're going to introduce this microbroth dilution assay and look for MCR genes and chromosomal mutations that confer resistance. Now, I want to show an example from one of our partners at UC Berkeley, who have new approaches to link these genome exchanges between different bacterial species, the way we want to do for colistin. Now, they have identified a particular technique, which they call context-seq, which is a CRISPR-Cas9 targeted sequencing of antimicrobial resistance genes. And they use nanopore sequencing so they can get genomic context for these resistance genes. So they investigated the AMR elements that contain antimicrobial resistance genes targeting CTXM and TEM, and they looked at feces of adults, children, poultry, and dogs within households. And what they were able to do then is, because the CRISPR-Cas9 targets these specific resistance genes, they were able to identify gene clusters that associated with BLA-TEM and BLA-CTXM. And they were able to find these gene clusters on the right that were associated with TEM, here indicated in green. And for each household, they looked for which of these gene clusters are found between humans, dogs, and chicken. And you can see these clusters of genes were found within households. And so they're purely doing a human ARG surveillance and looking for how are these elements moving from one to another. And because they use long-read sequencing, they're able to identify whether these genes are chromosomal or plasmid located. And again, the risks of the location, I think I've emphasized enough already. So let's move now to the use case 3, which is outbreak detection. Now, we know that a lot of infections are acquired within healthcare contexts. We know that healthcare-associated infections are some of the biggest problems. And so in some of our hospitals, we've been able to identify, in this case, an outbreak of multi-drug resistant Acinetobacter baumannii, which belongs to strain type 2. And as you can see on the antibiogram on the top here, that they're resistant to meropenem, which in many hospitals is the last line drug, but also with rapid acquisition of tigecycline resistance. And so this, again, is not the kind of bug you want in your hospitals. What's unique about this outbreak is that we first detected it in 2015, and it persisted all the way through 2018. And we still see these isolates in the hospitals to date. This is for Acinetobacter, which is notoriously difficult to clear from hospitals. This is a recent outbreak that we detected last year of a pan-drug resistant Pseudomonas aeruginosa, again in one of our study hospitals. And we first detected it in March, and it continues now. We're up to more than 20 cases. What was unique about this outbreak is that in all of our years of surveillance, we had never seen this ST773 Pseudomonas. So it's just suddenly popped up last year and moved very quickly within the wards. And you can see it spreading between the ICU, the outpatient, and the wards over this period of time. And using our genomic surveillance, we were able to identify the index patient, who was the first one that introduced it to the hospital, and we could map how it spread. Now, this strain, again, is really bad because it's resistant to colistin, which is the last-line drug, and meropenem as well. And what was also interesting is that it's related to strains in Asia, and that is likely where it was introduced. And we suspect that it's because of a lot of medical tourism to Asia, that maybe some patients who went for treatment there came back and introduced this into the hospital. And as I mentioned, we still pick up ongoing cases. Now, what I'm showing you is the power of genomics to tell us about outbreaks, but how do we prevent outbreaks from occurring? And to illustrate that, I want to show you this paper that was done in University of Pittsburgh that was just published a few months ago. And they decided to do something different from what we do. So instead of looking for isolates and doing whole genome sequencing on them, they just do routine, weekly, prospective sequencing of their patient isolates. And they've been doing this for 2 years. So whenever 2 or more patients with closely related isolates are identified, they tell their IPC team, and the IPC team immediately ramps up education of staff, they enhance their cleaning efforts, they implement hand hygiene and PPE compliance, and they enhance microbiological surveillance to identify the source. So the genomic data is linked very quickly to action. And as a result of this, you can look at the number of outbreaks that they were able to detect, and they were able to intervene and prevent 62 outbreaks and 5 deaths. And because of that, they've been able to save $700,000, which is more than threefold return on the investment. So they're able to prevent infections, improve outcomes, and strengthen patient safety. So what does this say? It means that whole genome sequence surveillance is useful because it highlights the problem, but it can only have substantial clinical impact if it's coupled with infection prevention and control interventions, and also if it's done routinely in real time and not reactive. So I think the take home here is that, yes, many of us now can sequence, but sequencing alone will not do much. So what's the missing piece, and why do we still see these outbreaks in our hospitals? It's because IPC is very weak. And this is confirmed by the African Union AMR Landmark Report of 2024. And its conclusion was that Africa falls behind on key AMR interventions, especially IPC. And the table here shows that in Africa, our infection prevention and control is at 13% compared to the global average of 39%. And so really, without going back to the basics, our genomic surveillance will not do much. So just washing hands, for instance, coupled with genomic surveillance, would really give us the power that lies in these new techniques. Use case 4 is, how do we identify AMR sources and transmission cycles, again in that One Health space? So if I show you these pictures and ask you this question, where do you think is the highest risk for acquiring a community multi-drug resistant infection? On the left, these are just fun pictures of things that are typical in many parts of Africa. On the left is water we interact with, water we drink. In the middle is animals, whether it's livestock or domestic animals. And on the right, these are many things that we see in our markets: fresh food, milk, street food, which tastes delicious. But are they some of the highest risks for acquiring community multi-drug resistant? So in our study, we looked at this as a very complex problem. And you say, what's the right question or approach so that we can accurately measure these human, animal, environmental aspects of AMR? And again, when you're solving a complex problem, you have to be ready to uncover some hidden assumptions, and also have, the more knowledge you have, there's some trade-offs that you don't anticipate. And so this is kind of what we found in our study. So one of the interesting things we observed is that for Pseudomonas aeruginosa, it's a common healthcare-associated infection, but in one of our counties, we noticed that 90% of patients with Pseudomonas infections, many of which were multi-drug resistant and resistant to these last-line drugs, were not coming from the hospital, they were coming from the community. Now, Pseudomonas is not peculiar, but it's one of its distinct characteristics is that it likes very warm and moist environments. So you find it associated a lot with water systems, moist surfaces, including moist wounds, as you can see here on this wet wound where you can see the characteristic green pigment. But it also forms biofilms in taps, and you can culture it very easily from this. So again, it's stubborn that it's associated with water. So we framed a question and said, let's go look at water in the community and see what is driving it. So on the left here, we were able to identify community reservoirs of Pseudomonas in this community where the patients were coming from. And indeed, here on the left, you can see that a lot of the Pseudomonas was not in the hospital, but was mostly in the community, confirming what we had observed. And you can see here that we found it mostly in households and within schools. And it was associated again with water tanks. So here you can see in household, it was associated with taps, and in schools, it was associated with tanks. So again, this it is counter to conventional wisdom where we didn't find it in hospital tanks, but we found it in tanks within schools. The other surprise was that we expected that these informal water sources, these we call them commercial water points, would be more contaminated, but we actually found that it's these piped taps that are more a reservoir in our community. The other surprise was that when we looked at the areas around the hospital that we surveyed, we found the highest prevalence in Milimani and relatively low prevalence in some of the low-income houses. So these are some of the low-income areas in that region. But we found the highest in Milimani Estate, which in this YouTube grab cheekily calls it the Europe of Kisumu City. So again, you can see how some of our assumptions are overturned, that it's in the high affluent regions, it's within our schools, and it's coming from our piped water and not from informal water sources. So there's a very clear link between water sources and Pseudomonas. If we look at a bug like Salmonella, I picked two studies that I want us to look at here. And the Salmonella is typically associated with humans and also with animals. And so this relationship between the two has been studied all the way from an early paper in 2002 that used pulsed field gel electrophoresis, which is an old classical typing a system to look at whether the strain types between humans and animals were linked. And you can see here on the left that all the human strains clustered together and all the animal strains clustered together, and there's very little interaction between the two. So it was suspected that animals and human strains are not the same, and animals are not reservoirs for human infection. A more recent study in Uganda from 2016 also looked at this more extensively, and they looked at cattle, poultry markets, human blood, human feces, and the environment. And this figure shows you how distinct the strains from cattle and poultry are versus the strains from humans and the strains from the environment. These types of data kind of go against what we think about One Health, where we think there's free flow movement between sectors, but actually in some cases, the strains in each sector are very distinct and there's no movement between them. Now, one of the methods that I used for studying particularly community antimicrobial resistance genes is wastewater surveillance, which is a method for early detection of diseases that has been very successful for pathogens like Shigella, polio, and COVID-19. And this analyzes wastewater for markers of pathogens and antimicrobial resistance genes. And you can see that the water consolidates all of the effluent from neighborhoods. So you can do community level surveillance. And also you can do healthcare surveillance just by looking at the healthcare wastewater. And this allows us to track resistance trends across different populations and across different regions as well. So it's a very efficient way to do surveillance if you get it right. There are two really important papers that summarize what the advantage of sewage or wastewater surveillance is. This one on the top says that there are some opportunities. One is that it can complement clinical surveillance by telling us very early what new resistance genes are emerging and what new antibiotics are emerging. And we can track these over time and space so that we can predict and detect outbreaks very quickly. Again, it gives us community, not patient level data, which is also useful. And we can use it to also evaluate how well our interventions are working and identify which populations are at high risk. So much like I showed you the map of MRSA and carbapenemase, the genes, we can do risk mapping at a community level. One of the biggest challenges is that the quantification of AR of bacteria and resistance genes is too variable to reliably track in space and time. And so some of the mitigations that are suggested by this paper on the right is that we should focus not on single sampling times and points, but do composite sampling so that we can average out the resistance genes and hopefully get more consistent numbers of or levels of resistance genes or bacteria, and then to do wastewater surveillance over long periods of time so that it spans seasons and all those other variations. And the most important one is that you must match your wastewater with human surveillance so that you can interpret what that data means. And the increase in more sophisticated genomic approaches, as you can see in this graph on the right, has made all these things very possible. And so in our group, we're really trying to understand what is the utility of wastewater surveillance for antimicrobial resistance. And so we've identified a closed community, which has a separate sewage system, independent water sources, water tanks, includes humans and animals within that same setting. And what we want to do then with that closed system is to really understand what does the sewage surveillance tell us vis-a-vis our human surveillance for both enteric and escape pathogens, and what compartments belong to the human, the water, the sewage, compare that very well with our metagenomic surveillance, and hopefully begin to understand what role does wastewater surveillance play in antimicrobial resistance. So let me move to my final use case. And I thought, what is a talk without artificial intelligence nowadays? And I thought I'd give you some examples of how artificial intelligence is impacting the AMR space. One of the biggest challenges in antimicrobial resistance is how the pipeline for new antibiotics has dried up. And this on the left is a World Health Organization report that shows the numbers of antibiotics that have been approved, and you can see how few come out of this pipeline into the market. So, and you can see that in the last 5 years, we only have a handful that have come out. But with the advent of artificial intelligence, a paper in 2020 demonstrated that a deep learning model had identified a powerful new drug. And this was using a prediction model where it screens a library of molecules and it learns the patterns in their chemical structure and then looks at how they interact with bacterial molecules. And they use this to identify novel compounds with antimicrobial potential. So this depends on existing libraries of molecules. The second paper that was published last year said that they had come up with a completely brand new structure, almost out of the air. And this used a generative design, which creates entirely new chemical structures. And this is very exciting because many of our new drugs are just modifications of old antibiotics, but they're not brand new molecules. And so this, I think, shows the power of AI to solve some of our biggest problems. So one of the papers said, so instead of having to wait 5-6 years to come up with one candidate, now on the computer, we can in a few hours come up with hundreds of thousands of candidates. So AI is solving our drug discovery problem because it can come up with many candidates. But remember that that is just the first in a step to getting antibiotics to market. You have to then do preclinical studies, clinical trials, and go through regulatory approval, which still takes more than 10 years and costs many, many millions of dollars. And so AI can solve some problems, but not all of them. So I think just as I wind up here, my biggest challenge is how do we apply AI to all of the big data that plagues us in the antimicrobial resistance space? So in the example I gave you before, they gave AI drug compounds and bacterial protein structures, but what else can we give it? Should we give AI our national surveillance data, our farm antibiotic use data, our antibiotic levels in rivers, our wastewater data, our Google searches, prescription data? What data can we give AI to help us solve this problem of antimicrobial resistance? So let me summarize by just giving some highlights of what we've talked about today. And I think one of the main things is that we must use global approaches across sectors to combat AMR. We still appreciate that hospital environments remain the key contributor in human health to the spread of multi-drug resistant infections, and that the key, in as much as our techniques get sophisticated, our key always goes back to the basics: infection prevention and control. How do we change our behavior, like hand hygiene? We need to eliminate reservoirs that enhance transfers of resistance genes. And we said that maybe our focus on bacterial strains is misaligned, since they may be restricted to the environments, as we saw for Salmonella, but genetic elements are not restricted and they can move between strains. So perhaps we need to change the focus of our surveillance to looking at mobile AMR genes. And then finally, how do we leverage AI to mine all the big surveillance data? As I wind up, I want to acknowledge our funding partners, our partners and collaborators. We work with many institutions, both in Kenya and outside of Kenya. And I've presented a lot of work, and this is done by the team in the MicroHub Kericho, and you can see some of their pictures on the right here. And we have host institutions. We're based in the Kenya Medical Research Institute. Our other host institution is RARE, and the research is supported by AJF MRI. So I'm going to end there, but I've left my email address in case anybody would like to get in touch. And with that, I'll hand back to you, Sylvester. Thank you so much for your attention. I appreciate it.
Wow, thank you very much, Dr. Lillian. Yes, please, for those that would really like to reach out to Dr. Lillian, please take note of her email and feel free to reach out to her directly. Otherwise, thank you very much, Dr. Musila, for such a comprehensive and insightful presentation. You've clearly shown how AMR surveillance, when combined with robust analysis and strategic dissemination as well, can help really shape effective interventions. Whether we are looking at the hospital level, in public health programs, or in policy development, I think you've really, through the case studies that you've highlighted, have shown how we can use this information to improve these aspects. Really, again, much appreciation on the chats. We have a lot of thanks, and also like to acknowledge Prof. Revathi from Kenya, who's also has appreciated you in the comments. So I think we'll just get straight to some questions and comments that are there on the chats. There are a lot. We'll try as much as possible to go through them. So I will start off with a question that was posed, I think, around vaccines. This is a question all the way from Guy Arnold Rogue from Gabon. He asks, his face says, "Thank you very much, a very relevant topic and nice presentation." He's just wondering how vaccines select strains. I think you did talk about vaccines also now. Sorry, certain strains now becoming overcoming some vaccines when we introduce them. So he wants to know how the vaccines are selecting for certain strains, and also considering how hard it is to make vaccines that can target all the strains. Do you think that vaccines are still relevant in the adult populations? Yes, I just want to get your thoughts on that. Thank you.
Yeah, thank you for that question. It's so interesting how we associate that kind of strain displacement with viruses. So we know that every year the flu virus, for instance, has to change because the virus has changed so much. And I think we don't think about it as much in the bacterial space. But it's a challenge, especially for an organism like strep pneuma that has so many serotypes. So you can't put all of them on your vaccine. You have to select the strains that you pick. And so the vaccine is actually very effective because it protects against infection against those vaccine strains. But the other minor strains then suddenly are people are not immune to them, and so they can begin to cause infections and they can begin to move rapidly within the population. So that you have new unprotected strains of strep pneumo, and the vaccine strains have all been replaced. And so when you replace them, one paper just observed that the replacement strains tend to be more virulent. And so there's a way that when you knock down some dominant strains, some minor ones occur. And we saw that, I think, I demonstrated that with E. coli as well, that if some event happens that knocks down some strains, there are others that are waiting to take over that space. And so I think that's how that works. And so what it means is that within your population, you can't just administer a vaccine for 10 years without doing any monitoring, because your vaccine could be doing sometimes more harm than good, and it could be very ineffective. So I like your question, is this the right strategy? And I think it is, because it does prevent a lot of deaths. So we can't remove it entirely, but we do need to monitor it. Thank you for your question.
Thank you very much, Dr. Musila. I think, yes, I agree with you that vaccines have really helped save lives over the many years that we've been implementing them. I'll move on quickly to the next question, and this one is kind of related, coming from Mariam Toure. She says, is the cephedral resistance suspected to be a natural resistance, or do you suppose these are also imported resistance, as was the case for the new cholera types?
Oh, that's such an interesting question. Thank you for that. Gosh, we'll have to just all speculate because we're not sure. We know that it's a fairly expensive drug, and that's why it's being sponsored for its introduction. So we don't think that there's been widespread use, but we did talk about medical tourism, and perhaps in other places they're able to use it, and that could be one of the drivers. But we also know that it's not uncommon that in a place where an antibiotic doesn't exist, that you do find spontaneous resistance, spontaneous mutations that can confer resistance to drugs that have not been shown. Now, our danger is that this could be a spontaneous or a random introduction, but the minute then you use cefiderosol, then you'll enrich for these strains and you'll see the resistance accumulating much more rapidly. And that's why we have to really monitor what's going on. I think that the reassuring thing for us is that these are chromosomal mutations, so they're not sitting on plasmids, which can move very fast. So we anticipate that this resistance will maybe emerge slowly, but again, it's something that we'll monitor.
Thank you so much, Dr. Musila, for that. Another question from Dr. Rama Golicha. He says, great talk, Dr. Musila. What are your thoughts on discussions around the phrase, not all AMR genes are functional, and assessing the resistance phenotype is therefore critical? She says, could you shed more light on this and share your perspective?
Yeah, thank you so much. Yeah, that's a big debate, huh? And especially the genomics people think they can take over microbiology, but they really can't, because we really need that phenotype data. So we're lucky here that we do a lot of phenotype and genotype work concurrently. So we're able to figure out how many of those genes actually translate to a phenotype. And I think what we found is that there's fairly good concordance between a resistance gene and the demonstration of phenotypes. Now, the thing that's rich about genomic identifying resistance genes is that you can identify many more than you can test in the lab on the bench. So it gives you an indication of the scope of resistance. But the phenotype is obviously the gold standard, and so we do see some discordance. So it's very dangerous to run with just genomics without some phenotypic backing, especially if you're seeing some novel resistance phenotype. So for instance, for this cefiderosol resistance that we observed, it's very new. And so it hasn't been robustly tested phenotypically, again, because it's a new drug. And so that's something that we need to layer on before we begin to shout from the rooftop that it's cefiderosol resistant. So you highlight a real danger and a bit of a tension that we have to leverage.
Thank you very much, Dr. Musila. I think that's a very important aspect of always just remembering that, we get more insights and there are these new innovations, but we also need to think about what is the gold standard, what insights are we
Yeah.
getting there and correlating that. There's a question from July Awino Okonji. He or she says, what would the presence of colistin resistance mean in a human population, especially when you find in almost every sequence within a defined population?
I think colistin is a drug that people had forgotten about, because it has a lot of toxicity in humans. So when your patient has a very highly multi-drug resistant infection that is resistant to last line drugs, carbapenems, your carbapenem combination drugs, and literally you have nothing left on the shelf, then people treat you with colistin. And colistin is still a very effective drug. It will kill the bug, but it might harm you. So it's like the last thing that you have in your cupboard, that could mean life or death. And so the appearance of colistin resistance in the human population is essentially wiping out our arsenal for human health. And so I think that's the significance of it. But if we have clinicians in the house, you realize that they use it with caution, but they're having to use it much more. And so I think that's the danger of it. And if you saw from the picture that we suspect that the drivers are animal health. So that's why they're putting it on the high priority to stop its use there so that we can preserve it for human use. I hope I've kind of addressed your question. Thank you for that.
Thank you very much, Dr. Musila. There's one very interesting question now that's looking at some of the technology I think that you highlighted. Again, a question from Dr. Rama Golicha. She says, thanks once more for the great talk. Interesting novel approach using context sec for One Health AMR surveillance. How does this approach compare to metagenomic sequencing? And then for those that do not know what context sec is, just to highlight that this is a method that combines CRISPR technology, so CRISPR targeted sequencing with long read nanopore sequencing to analyze AMR genes, the resistance genes. Yes, over to you, Dr. Lillian.
Gosh, yeah. This approach really intrigued me, and I think the advantage it has over metagenomics is that number one, it's targeted, and number two, for metagenomics, sometimes your antimicrobial resistance gene levels are so low that you can't detect them in the noise. So this technique is an enrichment technique, and it also amplifies the signal so you can detect it. So if you're interested in monitoring, for instance, for us, we're interested in colistin, I can use a CRISPR with a guide RNA that targets MCR genes alone. And then in my complex sample, then it will just kind of pull out anything that and then tag it, then I can only retrieve the sequences of MCR genes that I want. So it helps reduce that problem of metagenomics. What do you do with all this background? And usually the nonsense is like 90% of what's in your sequence. So I think those are the advantages, but it's such an interesting approach uh, if you have a particular thing that you want to target. In the paper, it was TEM. So perhaps you have something that you want to track keenly. That would be a really good approach to use.
Great. Thank you so much, Dr. Musila. Really helpful. In the interest of time, due to time limitations, we'll take one last question and then before we go to closing remarks. But please rest assured, we have taken note of all the questions that have been asked. We'll compile these and then send them to Dr. Musila, and then we will share the responses later. So the last question, I think, trying to bring in the policy aspects, Dr. Musila. There's a question here from Adebola Adetunji, who says, thanks for the great presentation. What are the key challenges in translating AMR surveillance data into actionable guidelines for antimicrobial stewardship teams in hospitals? So what are
I think
some
one
of
of
the
the
challenges?
challenges is what I highlighted there is that is that is it is it is our information is it regular and is it timely? So if our information, if I'm analyzing my samples from early this year and I find something, how useful is it? So there has to be a timeliness to that data. And then there also has to be some kind of communication between a lab like mine and the hospitals that we work in, so that we have to have a very close partnership with the IPC teams there. And we also need to kind of demystify what genomic data means to a busy clinician or a busy IPC practitioner. So what we're trying to do now, and I mentioned that in our national surveillance, we're introducing also a genomic surveillance component so that we can marry all these players together. This interdisciplinary team needs to work together and find out, what do we do with genomic data? What do we do when we suspect there's an outbreak? What do we quickly implement? And so for our national surveillance, we always try to, when you do surveillance, we also train on IPC and we also talk about genomics. So these compartments, I think, need to live together, and we need people to translate genomics into public health. And we still don't have a lot of people occupying that space.
Thank you so much, Dr. Musila. I think that was a very comprehensive response. So please, once again, Dr. Musila, really thank you once again for your presentation and really for engaging with all the questions that have been posed. Your examples, I think you've covered from tracking MRSA hotspots in Kenya to also leveraging water surveillance in the AMR surveillance. And even also you touched on AI for AMR data mining. Really, this has really helped highlight some of the diverse ways that surveillance data can help guide targeted interventions. So at this moment, I would really like to invite you for your closing remarks before we close off for today. Please, any last remarks from yourself? Thank you.
Yes, Sylvester, thank you so much for putting me on the spot. But AMR is a problem that I sometimes regret getting into because of how complicated it is. But it also challenges us as multidisciplinary stakeholders to really think smart about how can we begin to make headways into this space and begin to move the needle. So I think we don't have the luxury of kind of faffing about, as in just keeping busy, but we have to really think about what is a clever way for us to actually begin to have an impact. And so maybe that's the challenge I would leave for everybody, whether you're a clinician or an hospital practitioner, whether you're a pure researcher, a basic scientist, a genetic epidemiologist, whether you're a public health practitioner, what can we do to actually begin to move the needle? These statistics are depressing, and we need to start making a change. So thank you so much, and I really appreciate the privilege of addressing this audience. Thank you for the invitation, Sylvester.
Thank you so much, Dr. Lillian. We are also just very humbled and pleased that you were able to come through. So thank you once again for your time. Please, as we close off, please take note that the slides and presentations will be shared via the email that was sent out with the registration links. And also this will be made available on the ASLM website. If you haven't joined the ASLM as a member, please, we invite you to check the available membership on the ASLM website. Membership also gives you access to resources, training, and updates via the ASLM Academy portal, and provides you also with alerts to webinars such as the one that you've just been a part of today, and so much more. So really, it has been truly an enriching session, and we really are grateful to Dr. Musila for coming to share her experiences and the collaborations that they've been doing in Kenya and beyond. We look forward to seeing you in our upcoming AMR CoP webinars. We'll continue to share practical approaches for tackling antimicrobial resistance. Wishing you all a productive day ahead and a blessed weekend ahead. Until next time, it's goodbye for now. Thank you.